Welcome back to It's Your Case, presented by VetCT.com. I'm Heather Chalmers, your radiologist on demand for this week. This week's example is a 12-year-old mixed breed dog with some neurologic signs, summarized as T3-L3 myelopathy. It's a common scenario at both referral and probably primary practices. You have to often decide what would you consider to be baseline data before you go to a costly procedure like, for example, in this case, an MRI. So it was elected for this patient to perform thoracic radiographs merely as a screening procedure prior to the MRI. We see quite a lot of this in my line of work. What are some reasons for this? I think that we would want to screen before MRI for comorbidities that might alter the case management. That could include identifying, for example, a neoplastic process that might change the veterinarian or the family's plan for the patient. It could include evaluating for cardiopulmonary abnormalities prior to general anesthesia, or it might be that as you were collecting the history on this case related to the T3-L3 signs, that you discovered something such as a cough had occurred. There's all kinds of different reasons that we might sort of screen a patient with thoracic radiographs, and this is, like I said, quite common in the referral setting. And my sense is that it also can occur in the primary setting, again, just depending probably on the patient and the scenario and on your practice philosophy. So as you watch this video, of course, you might be thinking in the back of your head about your reasons and how you would manage a case like this. But what I'm going to focus on is what we can do when we find nodules in these patients, because this is a scenario that I often encounter at work. So last week we talked about when we're looking for nodules, we're going to get in really close, and I really like to look at every lung field on every view individually, giving its own time. And once I start finding things that I'm getting suspicious are looking round and nodular, and I'm going to kind of start flagging them here, then I really start to put together in my mind, they're all over the place here, okay? I really start to put together in my mind some thoughts about what could be causing pulmonary nodules. So in this case, of course, we said, well, we're screening for metastasis. So one of the first things that it makes sense that we would all think about is metastasis. I'm going to jump to the other view just to show you in this particular case, this is an example of pulmonary nodules that are seen on all views in all lung fields. They fit all the criteria that I have for soft tissue nodules. That includes that their size is 4 millimeters or greater. They're located not necessarily in line with pulmonary blood vessels, and you can see how their opacity is of a soft tissue opacity, not an increased opacity like a mineral or a summation of a blood vessel. So what I mentioned last week is that I comb all the lungs on all the views, and in doing that in this case, my suspicion or my findings are only further confirmed. Everywhere I look, all views, all lung fields, I'm finding nodules. So here's a case where we can clearly conclude nodules, but what else do we want to pay attention to on this radiograph? Well, I definitely, in a case like this with T3-L3 signs, I would really amp up my assessment of the vertebral column. I do this routinely in every case, but I want to use this as a way to kind of go through what my process would be, okay? The vertebral column has some complex anatomy. So I like to approach it in stages, and on the lateral view, I find I can see things better. I do go through it on the VD view as well, but especially in the thoracic spine, it's really hard to see on the VD view. So where do I start? I start dorsally and I move ventrally, and I usually do 3, if not 4 passes. A case like this, I'm definitely doing 4 passes because I'm suspicious of neoplasia, and we know that the dog has T3-L3 signs. Where I start is spinous processes. It won't take you long in your career before you're going to find one of these days a spinous process is going to be just flat out missing, or it's going to have a big lytic defect in it. So don't allow that to catch you out. Always look at all the spinous processes. The next thing that I do is I look at the joints. So the joints are in the thoracic spine a little bit harder to see just because we've got rib heads in the way. But here I'm pointing to the synovial articulations. This radiolucent crescent here, this is the actual articular cartilage and synovial fluid, or as we like to call it, the radiographic joint space. So my first pass, spinous processes. My second pass, joints. My third pass is going to be vertebral canal. So this is just kind of this whole area where I know the spinal cord is going. And as I do that, I can look at the intervertebral foramen. So the size of these foramen, whether or not they have normal opacity, etc. You can see, I'm going to zoom out so we can see a little bit more. Here in the cranial T-spine, I see the foramen really well, these lucent areas. As we go back here, we have a little bit of obliquity, the rib heads are in the way, and so I'm having a little bit of a technical difficulty seeing the foramen. My next pass through the spine is going to be vertebral bodies and discs, and I tend to do that as one, although here's another example. Because we're so worried about the vertebral column in this dog, I would probably do the the vertebrae twice, once for discs and once for vertebrae. What am I looking at for vertebrae when I'm worried about neoplasia? I'm looking for things that are more lucent, and I'm giving an example here. I want to flag this as something that I did not think was concerning in this patient. Can you see how multiple vertebrae are more lucent? So instead of me thinking that they're lytic, I think that this is just an artifact of superimposition. We can see that the ribs are up here, whereas in the cranial vertebral column, the ribs are better aligned. So if I had only one vertebrae that was really lucent and the margins of that lucency didn't align so well with the ribs, I might have been more concerned. But in this case, I felt pretty comfortable that the skeletal structures were unremarkable and that we really hadn't found a primary neoplasm. So when we can clearly conclude nodules, we know, of course, that these may be metastatic from a primary neoplasm that we haven't yet identified. Primary pulmonary carcinoma would not usually present as multiple small nodules. It would be more common for it to have sort of one primary nodule declaring itself, even if there were multiple nodules as a result of metastasis. So I would have that as much less likely. And lastly, we could not exclude fungal granulomas. I focused on neoplasia due to the clinical scenario, but we would need to know the exposure history to fungal agents in this patient's geographic area, and if needed, we could consider screening for endemic pathogens. So, be sure to review the full report associated with this case and join us next week for further examples. Thanks for listening, and remember, it's your case, so please post your questions on social media.